The patient with a respiratory disease. Patients with respiratory diseases have increased risk for complications due to decreased breathing function and treatment-drug interactions. Tobacco cessation. Many respiratory diseases are caused or aggravated by the use of tobacco products. Dental hygienists have a unique opportunity to educate their patients about the health hazard. Emergency treatment. Patients with respiratory distress may need emergency care, with dental hygienists are prepared to prevent or provide when necessary. Signs and symptoms and medical emergency procedures for local anesthesia reactions, respiratory failure, airway obstruction, asthma attack, hyperventilation, anaphylaxis, and allergic reactions. Oral systemic link. Scientific evidence shows dental biofilm and microorganisms from periodontal infections can contribute to the initiation and the progression of certain respiratory infections. Dedication of the dental hygienist to the prevention and control of the periodontal infections can have a major influence on the overall health of the patient. The respiratory system, the anatomy, structures, sinuses, nasal cavity, larynx, pharynx, trachea, bronchi, lungs, and pleura. Physiology. The respiratory tract from the nasal cavity to the lungs serves as a passageway for airway exchange. Inhaled fresh air, warmed and filtrated in the nasal cavity, it enters the lungs. Exhaled air, with carbon dioxide, it leaves the body. Gas exchange. At the cellular level, occurs in the alveoli at the ends of the bronchioles. Cardiovascular system. Functions with the respiratory system to pump oxygenated blood from the lungs to every cell in the body and deoxygenated blood back to the lungs for exhalation. Function of the respiratory mucosa. The figure down below shows ciliated epithelial cells and the mucus-secreting goblet cells that line the respiratory tract to make up the respiratory mucosa. Mucus secreted from goblet cells moistens inspired air, prevents delicate alveolar walls from becoming dry, and traps dust and other airborne particles. Cilia assist in removing foreign materials and contaminated mucus by a constant beating in wave-like motion that propels this material back into the larger bronchi and trachea, where it can be coughed up and expectorated or swallowed. Lack of function results when the inflammatory process of asthma and chronic bronchitis initiates an overabundance of mucus. Congestion is created and the cilia are prevented from assisting with normal breathing. Respiratory assessment. Respiratory disease assessment includes several objective measures. We're going to start with vital signs. Determination of vital signs, body temperature, pulse, respiratory rate, blood pressure, and also smoking status is considered standard procedure in dental patient care. Spirometry. Medical test that measures various aspects of breathing and lung function. Used to diagnose and monitor many lower respiratory tract diseases. Performed with a spirometer, a device that registers the amount of air a person inhales or exhales and the rate at which air is moved in and out of the lungs. Pulse oximetry, medical test that measures blood oxygen saturation levels. It's performed with a pulse oximeter. Color of the blood vessels varies depending upon the amount of oxygen it contains. Pulse oximeter emits a light through the finger to calculate the percentage of oxygen. Any finger, excluding the thumb, can be used. Nail polish or skin callus may interfere with reading. Intended only as an adjunct in patient assessment along with other methods of assessing clinical signs and symptoms. Healthy patients have an oxygen saturation of 97% to 100%. Saturation of 90% or below signifies poor oxygen exchange. Chest radiography imaging indicates presence of pathologic density radiopacity in the lungs. Standard chest radiograph shows a two-dimensional view of the lung tissue. Computed axial tomography radiograph or computed tomography scan shows a three-dimensional cross-section of the lung tissue. Blood gas analysis. Blood test to determine acid-base balance, alveolar ventilation, arterial oxygen saturation, and carbon dioxide elimination. Cytology, body cells and fluids, and hematology evaluation. Examination of body cells, blood, and other fluids to determine the presence of microorganisms that can cause respiratory diseases. Samples are taken from sputum, pleural cavity fluid, bronchial biopsy, or blood. Classifications. Classifications of respiratory diseases. Upper respiratory tract diseases. The more common disorders of the upper respiratory tract are caused by infections or allergic reactions that result in inflammation. Signs and symptoms, etiology, medical treatment, and clinical evaluations assessments are summarized. Modes of transmission: inhalation of airborne droplets. Indirectly by contaminated hands are articles of freshly soiled with discharge of nose or throat of infected person. Dental hygiene care, disease prevention. All healthcare professionals are encouraged to obtain immunizations for seasonal viral influenza. Observe standard precautions including respiratory hygiene and cough etiquette. To prevent transmission of pathogens from patient to clinician and to prevent healthcare association infections to the patient. Appointment management. Delay treatment until patient is no longer infectious. Non-infectious status is determined by temperature returning to normal and regression of oral lesions such as erythematous lesion of the soft palate and erythema multiforme. Bacterial resistance to antibiotics. Bacteria may become resistant to antibiotics within 14 days. For patients currently prescribed an antibiotic for a non-dental condition, different category of antibiotics will be necessary to treat an odontogenic infection. Moving on to lower respiratory tract diseases. These are considered to be more serious infections. Acute bronchitis, an acute respiratory infection that involves large airways, trachea, bronchi. Primary symptom, cough with or without phlegm, may last up to 3 weeks. Lower respiratory tract disease symptoms, wheezing, shortness of breath, or chest tightness. Differentiated from pneumonia, no significant findings on chest radiography. Pneumonia, an infection and subsequent inflammation of the lungs that may be caused by virus, bacteria, fungi, mycoplasm, or parasites. The respiratory tract of a healthy person is able to defend against organisms aspirated into the lungs. With diminished salivary flow, decreased cough reflex, swallowing disorders, poor ability to perform good oral hygiene, or other physical disability, there is an increased risk of aspiration and respiratory infection. Etiology: viral and bacterial. Fungal. Etiology: agent of pneumocystis. Pneumonia is pneumocystis jirovecii. Susceptible to enhanced by chronic debilitating disease in which immune mechanisms are impaired, such as in HIV and AIDS. Symptoms: fever greater than 100.4 degrees Fahrenheit, productive coughs, chest pain, shortness of breath, visible on chest x-ray. Categories and role of oral bacteria. Pneumonia is often categorized by location and or procedure. Community-acquired pneumonia, infection occurring in an individual in a community, not in a healthcare facility. Person-to-person transmission. Healthcare-associated nosocomial pneumonia, infection occurring 48 to 72 hours after admission to the healthcare facility. A major cause of death in the hospitalized patients. Commonly multi-drug resistant pathogens, more common in the very elderly over 80 years of age and those with comorbidities. Bacteria and periodontal pockets may serve as reservoir for lung infection, especially in institutional settings. Bacteria from oral biofilm are released into the saliva and can be aspirated into the lungs. Contributing factors: poor oral health, dependence on others to perform daily hygiene, oral colonization of periodontal and respiratory pathogens, influenced by periodontitis are associated with nosocomial pneumonia. Nursing home acquired pneumonia, owing to dysphagia from decrease in saliva, cough reflex, and swallowing disorders. Aspiration of saliva can be the main route of bacteria into the lungs and may lead to aspiration pneumonia. Hospital acquired pneumonia. Ventilator-associated pneumonia, mechanically ventilated patients in the immediate care unit with no ability to clear oral secretions by swallowing or coughing. Non-ventilator-associated pneumonia, biofilm forms on endotracheal tubes and catheters. Medical management: viral, supportive treatment of bed rest and fluids, bacterial, antibiotic therapy, and fungal sulfa drugs. Dental hygiene care: control of oral disease and periodontal diseases for patients in nursing homes and hospitals will help prevent aspiration pneumonia. Use 0.12% chlorhexidine gluconate rinse prior to beginning treatment to reduce the bacterial load. Avoid using the ultrasonic scaler due to production of aerosols. Tuberculosis. Tuberculosis, or TB, is a chronic infectious and communicable disease with worldwide public health significance as a cause of disability and death, especially in developing countries. Groups at high risk for exposure to TB include those who have recently been infected with TB bacteria or persons with medical conditions that weaken the immune system. Those are at risk. Close contact with people infected with TB, residing and working in institutional settings, prisons, nursing homes, from countries with a high TB incidence and prevalence, injection drug users, people who use alcohol abuse, persons with HIV, patients with diabetes, severe kidney disease, organ transplant, head and neck cancer, patients undergoing specialized treatment for Crohn's disease and rheumatoid arthritis, malnourished or low body weight, medical dental care providers for any of the aforementioned high-risk groups. The etiology: Mycobacterium tuberculosis, a rod-shaped bacterium. Tuberculosis bacillus is the most causative cause and agent. Transmission: Tuberculosis bacilli travel in airborne droplets, nuclei, and infected saliva or mucus from persons with pulmonary or laryngeal TB during forceful expirations, coughing, sneezing, talking, and singing. The airborne droplet nuclei can remain suspended in the air for hours. Inhalation and other modes of transmission can occur. Disease development: Inhaled tuberculosis bacilli travel to the lungs, alveoli, where the local infection begins. While TB can affect any organ or tissue, M. tuberculosis is an airborne and survives best in the environment of high oxygen tension, such as the lungs. Latent tuberculosis infection, LTBI. Within 2 to 10 weeks following exposure, immune response will limit further growth of M. tuberculosis, although not all bacilli will be eliminated. At this stage, the infected person is categorized as having LTBI. Approximately 5 to 10% of people infected with M. tuberculosis and not treated for LTBI will develop TB disease during their lifetime. Comparison of LTBI and active TB disease, including symptoms and signs, diagnosis, and medical treatment with TB drugs. Diagnosis: latent tuberculosis infection. 2 tests are available to determine exposure to M. tuberculosis. Tuberculin skin test, TST, also known as Mantoux test, purified protein derivative, PPD test. PPD is injected under the skin on the forearm. After 72 hours, the circumference of induration, hard swelling is measured to determine exposure. A negative TST does not exclude TB disease in a person with signs and symptoms of TB disease. Interferon gamma release assay, IGRA, blood test to determine exposure to M. tuberculosis. IGRA blood test, as with TST, cannot differentiate LTBI from active TB disease. Laboratory sputum smear and culture is required. Active TB disease. When tests to determine exposure to M. tuberculosis are positive, further examination is required to rule out active tuberculosis disease. Chest radiograph, physical examination and evaluation of signs and symptoms. Preliminary diagnosis, perform microscopic examination of sputum smears for acid-fast bacilli, AFB. The waxy cell wall of tuberculosis bacilli does not absorb the traditional water-soluble Gram stain and cannot be identified. However, when treated with an acid stain, the organisms appear pink and are named AFB. Definitive diagnosis: when AFB are seen on a stain smear of sputum or other clinical specimen, a diagnosis of TB disease is suspected. However, the diagnosis is not confirmed until a laboratory culture is grown and identified as M. tuberculosis. Medical management: commonly prescribed drugs. Directly observed therapy. Observing the patient swallow anti-TB drugs is recommended for all LTBI and TB disease patients and will result in high medication compliance, prevention of multi-drug resistant bacterial development, prevention of multi-drug resistance TB, MDR, TB disease, which is more severe and difficult to treat. Drug resistance. TB bacteria can become resistant. Drugs are no longer effective in killing the bacteria. Types of resistance. Primary resistance. Individuals who have not been previously exposed to anti-TB drug treatments. Acquired resistance. Individuals who have been previously exposed to anti-TB drug treatments. This occurs frequently when a full course of anti-TB drug treatments is not completed. MDR, TB. TB bacterial resistance to at least 2 of the first-line most preferred drugs, ionazide and rifapentine. Extensively drug resistance TB, TB bacterial resistance to ionazide, rifapentine, and fluorohemolone in at least one of 3 injectable second-line drugs. Oral manifestations. TB infrequently appears in the oral cavity from pulmonary organisms and infectum sputum brought up through the mouth by coughing. Classic mucosal lesion, painful, deep, irregular ulcer on the dorsum of the tongue. Lesions can also occur on the palate, lips, buccal mucosa, and gingiva. A biopsy and laboratory culture of an oral lesion that reveals M. tuberculosis confirms a diagnosis of TB. Glandular swelling, cervical or submandibular lymph nodes infected with TB. Nodes may become enlarged. The dental hygiene care, implementation of infection control measures, update medical history, recognize signs and symptoms, refer to the web resource for CDC guidelines, create and routinely update written office clinic protocols, educated and training staff, instrument reprocessing and operatory cleanup, identifying, managing, and referring patients with active TB, assessing, managing, and investing dental staff with positive TST PPD. Management of patients with symptoms of a history of TB. Active TB disease and sputum positive TB. Do not treat in dental office or any outpatient facility. Treatment needs to be performed in a hospital with appropriate isolation, sterilization, and engineering controls. History of TB. Use caution. Obtain history of disease, treatment duration, and discuss signs and symptoms of disease and consult with physician before the treatment. Also consult with the physician if adequate treatment, time management, medical follow-up is unclear, and the patient presents with signs and symptoms or relapse. Recent conversion to positive TST or blood test. Treatment is permitted after patient is free of clinical active disease. Evaluation by physician to rule out active TB disease. Verification by physician of receiving ionized for 6 months to a year to prevent active TB disease. When the patient has signs and symptoms of TB, postpone non-emergency treatment and refer to physician. Moving on to asthma. Asthma is a chronic respiratory disease consisting of recurrent episodes of dyspnea, cough, and wheezing, leading to bronchial inflammation and muscle contraction. The etiology. The exact cause of asthma is not completely understood. The following types are based on pathophysiology. Extrinsic, allergic or atopic. Allergic triggers from outside the body. Most common type of asthma. Exaggerated inflammatory response triggered by inhalation of environmental allergens, dust, pollen, tobacco smoke, mold, dust mites, and animal dander. Allergic stimulus leads to activation of airway epithelial mast cells. Steps of an immunoglobulin E, IgE-mediated hypersensitive reactions occur. Intrinsic, non-allergic. Non-allergic triggers from within the body. Intrinsic triggers, emotional stress, gastroesophageal reflux disease, GERD. Trigger may be unidentified, obesity, usually seen in adults. Drug or food-induced, non-allergenic, non-atopic. Aspirin, non-steroidal anti-inflammatory drugs, beta blockers, food substances, nuts, shellfish, milk, strawberries, tartanzine, yellow food dye. Metabisulfite, preservative in foods, wine, beer, shrimp, dried fruit. Metabisulfite, preservative in drugs, local anesthetic with epinephrine. Exercise-induced. Vigorous physical activity usually affects young people. Thermal changes during inhalation of cold air may provoke mucosal irritation and airway hyperactivity. Infection-induced. Lung infections caused by viruses, bacteria, fungi. Treatment of the infection improves breathing. Atopic allergic asthma. Atopic asthma is one type of IgE-mediated hypersensitivity. Immunoglobulin E, one of the 5 types of antibodies produced by the body, provide the primary defense against environmental allergens, pollen, tobacco smoke, and food substances. Normal inflammatory reaction. IgE breaks down the allergen and removes them from the body. Normally, such activity does not produce noticeable symptoms. Asthmatic hypersensitivity reaction. People with asthma are believed to be hyperreact and produce more IgE antibodies than normal. The results can be symptoms of asthma, wheezing, coughing, and dyspnea. How allergens trigger asthma. Steps in an IgE-mediated hypersensitivity reaction. On initial exposure to the allergen, the dust, the pollen, the food, the immunoglobulins IgE are produced and bind to mast cells. On subsequent exposures, the antigen binds to the IgE on the mast cells. Mast cells release asthma mediators such as histamines, leukotrienes, and prostaglandins. Asthma mediators cause bronchoconstriction, vasodilation, and mucus production. The result is wheezing, coughing, and dyspnea. The summary of IgE-mediated hypersensitivity reactions. Local anaphylaxis. Allergen binds to mast cells in nasal cavity, results in allergic rhinitis or hay fever. Allergen binds to mast cells in the bronchiole, results in asthma. Systemic anaphylaxis, allergen, penicillin, bee venom, food substance, binds to mast cells throughout the body, results in a reaction sometimes referred to as anaphylactic shock. Asthma attack. Recognize signs and symptoms of severe or worsening asthma attack. Chest tightness, sense of suffocation, ineffectiveness of bronchodilator to relieve dyspnea, wheezing, cough, flushed appearance, sweating, confusion due to lack of oxygen, dilated pupils, inability to complete a sentence in one breath, tachypnea, and tachycardia. Prepare for possible emergency care. Recognize signs and symptoms. Stop dental hygiene treatment. Rule out foreign body obstruction. Assist with patient's own bronchodilator inhaler. Administer supplemental oxygen by nasal cannula. Assist with the administration of subcutaneous injection or inhalation of epinephrine. Monitor vital signs and call emergency medical service and initiate emergency procedures. Medical management, diagnosis, conduct physical examination and lung function assessment, the spirometry. Achieve and maintain asthma control. Assess and monitor asthma severity and asthma control. The National Asthma Education and Prevention Program classification is based on 4 levels of severity and frequency of symptoms, as well as pulmonary function assessment spirometry. Intermittent, persistent mild, persistent moderate, persistent severe. One second here. Education. Patients are advised to have a written control plan from the physician explaining the process of disease, treatment options, and how to treat exacerbations or worsenings of the symptoms. Control of environmental factors, pollutants and allergens, and comorbid conditions that affect asthma, GERD, obesity, obstructive sleep apnea, OSA, rhinitis, sinusitis, stress, and depression. Medications. There are 2 main types, long-term control medications and quick relief medications. People with asthma are divided into seasonal influenza vaccinations and may also benefit from immunotherapy allergy injections. Asthma triggers, potentially harmful drugs to avoid. Aspirin-containing medications use acetaminophen. Sulfite-containing local anesthetics such as epinephrine and NSAIDs. Avoid drugs that decrease respiratory function such as narcotics and barbiturates. Avoid harmful drug-to-drug interactions. Macrolide antibiotics such as erythromycin if patients take thiolanine. Erythromycin inhibits metabolism of methylmalonium, which can result in the increase in serum level and possible overdose. Discontinue cimetidine 24 hours before intravenous sedation in patients taking thiolanine. Oral manifestations. Beta-2 agonist inhalers cause a decrease in salivary flow and dental biofilm pH, are associated with xerostomia and possible increase in caries and gingivitis in patients inadequate biofilm control. Increase in GERD with use of beta-2 agonists and thiolanine, which may contribute to enamel erosion. Oral candidiasis occur with high dosage of frequency of inhaled corticosteroids. Occurrence may decrease with the use of spacer or aerosol holder chamber attached to metered dose inhaler. Rinse mouth with water after each use. Dental hygiene care. Okay, before and after and during the treatment. Chronic obstructive pulmonary disease, or COPD, is used to describe pulmonary disorders that obstruct the airflow. 2 of the most common types are chronic bronchitis and emphysema. Progressive disease that is not fully reversible, characterized by chronic inflammation of the lungs and the airway and continual airflow limitations. The primary etiology is tobacco smoke, with occupational and environmental pollutants as contributing factors. Tobacco accounts for 8 to 10 COPD-related deaths. Motivating a patient with COPD to begin a tobacco cessation program can be one of the most rewarding aspects of dental hygiene care practice. Chronic bronchitis. The etiology. Chronic bronchitis is defined as excessive respiratory tract mucus production sufficient to cause a cough with expectoration, coughing up mucus for at least 3 months of the year for 2 or more years. Obstruction caused by narrowing of small airways, increased sputum, phlegm, and mucus plugging. Difficulty breathing present on inspiration, breathing in, and expiration, breathing out. Signs and symptoms: chronic cough, copious sputum, chest radiograph abnormalities, sedentary, overweight, cyanotic, edematous, and breathless, leading to the term blue bloater. Emphysema. The etiology. Emphysema is defined as distension or widening of the air spaces distal to terminal bronchioles due to destruction of the alveolar walls or septa. Smoke injuries alveolar epithelium, destroying alveolar walls and creating large air spaces. Difficulty breathing only on expiration. Expiration means only on breathing out. Signs and symptoms: difficulty in breathing on exertion, minimal non-productive cough, dry, no mucus, barrel chest, enlarged chest walls due to increased use of respiratory chest muscles, weight loss, chest radiograph abnormalities, purses lips to forcibly expel air, leading to the term pink puffer. Medical management: confirm diagnosis with spirometry and determine severity. COPD is classified into 5 stages: at risk, mild, moderate, severe, and very severe. Reduce the risk factors: tobacco cessation, reduction of exposure to environmental indoor-outdoor pollutants. Examples: ozone and industrial air pollution, automobile emissions, household cleaning products, vaccinations for influenza and pneumococcal, education on self-management, periodontal infection, inadequate biofilm control, and lack of oral health knowledge are associated with increased COPD. Manage stable COPD. Relief of symptoms: aerosol bronchodilators, inhaled corticosteroids, and other medications similar to those that treat asthma. Pneumonia and seasonal influenza vaccinations, antibiotics for infectious exacerbations, pulmonary rehabilitation, including a structured exercise program to relieve symptoms and improve quality of life. Surgery: if severe emphysema, the removal of part or one of both lungs may result in more space for the remaining lungs to function. Lung transplant, oxygen therapy. A patient who uses oxygen to improve breathing function may hold a portable unit during treatment. Types: continuous flow, oxygen flows at a determined rate of liters per minute. On demand, oxygen flows during inhalation only, extending the period of time between oxygen tank refills. Precautions: oxygen promotes rapid burning. Keep away from heat, flame, or other ignition sources. Do not smoke cigarettes or have Bunsen burners near you when you're doing this. Oral manifestations: oral cancer, nicotine stomatitis, halitosis, periodontal infections, and extrinsic tooth stain. Dental hygiene care: before the treatment, assess severity of COPD and breathing difficulty. Treatment may be performed on stable patients with adequate breathing. Identify patients who may experience exacerbation of symptoms under emotional stress. Monitor blood pressure. Appointment length may be modified. Chair positioning: upright or semi-upright during treatment. Use antimicrobial pre-procedural rinse. Avoid the use of power-driven scalers and air polisher. Administer local anesthetic without epinephrine. Nitrous oxygen sedation. Avoid with severe COPD and emphysema. Patient education: encourage patient to stop smoking. Cystic fibrosis. Cystic fibrosis is an autosomal recessive gene disorder. Both parents must carry the genetic mutation for the disease to be transmitted to their child. CF is a progressive and ultimately fatal. With improved multifaceted health care, many people now live into the 30s and 40s. Disease characteristics: the gene disorder affects the movement of salt and water in and out of the epithelial cells in the respiratory tract and exocrine glands, respiratory, pancreas, gastrointestinal, and results in thickened secretions. Main systems affected are described as we go below. So the respiratory tract: airways are filled with phlegm, similar to pus, leading to chronic sinusitis, opportunistic bacterial lung infection, and both are difficult to eradicate even with antibiotics due to the ability of the Pseudomonas aeruginosa to form biofilm. Pancreas and intestinal tract: thick mucus clogs pancreatic ducts. Clogged ducts prevent the relapse of pancreatic enzymes into the intestinal tract. Without enzymes, food cannot properly digested or be absorbed. Medical management: antibiotics include inhalation solution, tobramycin sulfate nebulizer, bronchodilators, and anti-inflammatory agents. Chest physiotherapy, postural drainage, and percussion. Dental hygiene care: oral manifestations. No specific oral lesions are related to CF. Gingivitis is associated with a dry mouth. To facilitate breathing, adapt the chair and avoid the use of a rubber dam. The summary guidelines for dental hygiene care: sleep-related breathing disorders, usually due to chronic airway obstruction, primarily snoring and OSA syndrome are common sleep-related breathing disorders. The etiology: repetitive narrowing and closure of the upper respiratory airway during sleep, pharyngeal airway obstruction. In children, the most common cause is tonsillar hypertrophy. Signs and symptoms: interruptions in sleep patterns. Snoring may cause tissue inflammation. Wake up with dry mouth or sore throat, associated with comorbidities, motor vehicle accidents, and occupational exposures. Medical management: continuous positive airway pressure CPAP machine. Oral appliance therapy OAT is an effective treatment for mild to moderate sleep apnea and for severe sleep apnea when CPAP is not tolerated. The mandibular advancement device shown below is the most common form of oral appliance used in clinical practice. The mandibular advancement splint moves the mandibular slightly forward and tightens the soft tissue and muscles of the upper airway to prevent obstruction of the airway during sleep. Contraindications to OAT include periodontal disease, TMJ disorders, and insufficient number of teeth. Positional therapy to prevent postural drainage and weight loss. Dental hygiene care. Assessment of the oral tissues. Assess the TMJ. Recommend non-alcoholic based mouth moisturizers and rinse. Bring mandibular advancement device. Bring mandibular advancement device to continuing care appointment evaluation and documentation. Alerts for dental personnel to the possibility of disease transmission to medical emergency due to medical condition or an allergy.